All right, so we're going to talk about a topic that I think is very important, but isn't super widely practiced by the radiology community at large. We're a niche group. We love it. We swear by cardiac MRI, and I'm going to try to convince you in this talk why that's the case. So it's good for a lot of things. And so I'm going to go over some of the basics, and then we'll talk about major indications in line with my title, which is What is it good for? And you'll see it's good for quite a number of things, and some of which are unique and unreproducible by other techniques. So let's start with the basics. This is a slide I showed a moment ago for those of you who were in the last session, and just citing the advantages versus the pros and cons versus CT, and echo as well. So the wide field of view versus echo is a big advantage. The excellent anatomic definition is a great advantage as well compared to CT functional information. And of course, the downsides are what you all know about. The prep is not all that dissimilar to CT. You're going to need to have gating. There'll be a dedicated cardiac coil if you have a more recent MRI scanner, which will give you better image quality. One consideration, of course, is pacers and ICDs. Now, increasingly, there are MRI-tolerant ICDs and pacers. So it used to be we had a whole protocol when doing these, and we still do, but it's gotten easier. So to go as far as saying that you can't do cardiac MRI or any MRI for that matter in the setting of one of these devices is no longer really true. You just have to, find a conditional. You have to find out if they're conditional, and depending on what the situation is, haven't monitored. Valves, for the most part, are fine. So cardiac valves. All right, so let's just go through your basic assessment, and it's kind of a triad with a little bit of a supplement. There's what I always call the CT view, which is just an axial screen running through the entire thorax, looking for kind of anything, nodes, nodules, whatever, effusions. And then the big three really are the bright blood imaging, the first pass perfusion imaging, which is probably the least important of the three, and finally the delayed enhancement, also known as DME, LG, and other names like that. Those are the big three. With the we'll talk about each of these in some more detail. And then for selected cases, you can do T2-weighted edema sequences. You can do dark blood imaging as well. So there's a tremendous amount of versatility, which I mentioned previously, that really few, if any, other techniques are capable of doing. So let's go through and talk about starting with the bright blood sequence, which is today is a steady state free precession. We used to have a spoiled sequence, but now it's actually SSFP steady state. And essentially what it's good for is, it goes by different names. You may hear True FISP, you may hear Fiesta. There's other names depending on the vendor. But you can use it to assess wall motion. You can look at wall thickening of the myocardium. You can look at stenosis and regurgitation, something CT cannot do by and large. You can calculate EF, stroke volume, and other measurements, myocardial wall thickness, other things, which we do routinely. We do all those things routinely using these. Of course, we use cardiac views routinely with this as well. So short axis, you've all seen these 4-chamber views. You can do the same thing with 3-chamber and 2-chamber. And we also do specialty views, LVOTs, RVOTs, depending on what the indication is. For perfusion imaging, as I said, that's the weakest of the big three. It's kind of a first pass sequence. I'm showing it right here to look for particularly perfusion defects. And what you'll see, of course, is initially the RV will light up, then the LV cavity, and then the myocardium. And then finally, delayed enhancement. After you've given your gadolinium chelate, you'll wait about 10 minutes, and then the myocardium you'll null the myocardium, which means make it black. Using what's called an inversion pulse, and I'll talk a little bit about this in a second. And then you're looking for areas that are not black. So if you look at the lower image there, it's all black. That's normal. But if you have retained gadolinium for whatever reason, infarction, scar, increased extracellular volume, you will find that there will be retention of gadolinium and therefore high signal intensity. And how does this work? In a nutshell, without going into the physics, which I don't claim to be a physicist, essentially when gadolinium goes into the extracellular space in the myocardium, meaning it is out of the circulation, whether it's normal or in disease states, but generally it's going to be disease states, it gets stuck there. And it has far greater T1 shortening, so you can see the curve there on the right. Gadolinium zips back. If you give an inversion pulse, go -1, that's what that does. Gadolinium quickly returns to steady state, which is 1, whereas the normal myocardium relaxes in the red much more slowly. So what you're trying to do is pick the null point of the myocardium when it's 0, and that's when the green line, at which time the myocardium is black, but any retained gadolinium is back to 1. And that's why it's bright. And so that's where you're gonna wanna image. Okay, so that's essentially the physics behind it. And so when we look at that, looking for the null myocardium, we do a TI scout. It's an inversion sequence looking for this whole process to occur, going from -1, you flip it, go to -1 back to 1. And you're looking for that null point of the myocardium. And so what generally happens here, and I'm going to show it to you in a second, is that the myocardium, the blood pool generally becomes null first, and then the myocardium follows. So if you look at this, and this is important because that's what's normal, but if you see it reverse, meaning the blood pool nulls later than the myocardium, that's abnormal. So if you look, black blood pool, and then finally the myocardium nulls. That is a normal TI scout, okay? And then we're going to take that nulled myocardium point, and that's when we're going to do our delayed imaging. So it's often about 250 to 300 milliseconds after the inversion pulse is given. That's a typical time frame. And so this is just showing normal, delayed enhancement, and abnormal. Normal, just completely nice, symmetric, nulled myocardium, and then an area of abnormal myocardium. And of course, depending on the distribution of the abnormal myocardium, that speaks a lot to what the etiology may be. Okay, so that's by way of sort of an overview. Let's talk about some of the major indications. And of these, the one we do most commonly is the second, cardiomyopathy. But I mentioned ischemia is key, so I think we'll talk about that first, and then we can talk about some of the other things as well. But cardiomyopathy is our #1 indication, that, at least in our practice. Ischemia infarction, it does have a role. It's complementary to other things like nuclear imaging, and it does fine. It just isn't, so I'm going to talk about it, recognizing that we do less of it than some of the other things. So if you look at this table here, you can see in terms of the ischemic injury spectrum, there's really 3 levels. There's stunned myocardium, there's hibernating myocardium, and the one we deal with most is the last one, the infarcted myocardium. Stunned myocardium is basically where there's a momentary, this could be a temporary occlusion of a coronary artery where it resolves, and the myocardium's stunned, but then it resolves eventually. So in that case, the wall motion is abnormal, but there's no viability, there's no contrast that gets out of the vessels, and so everything else is normal. Hibernating is generally a downregulation, more chronic. The myocardium's alive, but it's kind of sleeping, and therefore the perfusion and wall motion are abnormal, but the viability is the perfusion of wall motion is abnormal, viability is normal. And infarction, everything's abnormal all through it, and that's the situation we deal with. So this is stunned myocardium, what that looks like, and you can just see that probably it's best seen in the right side of it, where end diastole, end systole, after, which is the last 2 images there on each one. In the case of reverses, everything is okay again. That's normal. But if you in an infarcted myocardium, it doesn't go back to normal. So that's the distinction. And as I said, we don't usually image this ourselves. Hibernating, we do a little bit more, and this is, as I said, a more chronic state where it gets downregulated, where there's basically poor perfusion, but not enough to cause infarction. And so generally in this case, the wall motion is going to be abnormal. So if you look at the lateral and infralateral wall, it doesn't look so normal. Septum doesn't look as bad. If you look at the perfusion image next, you can see it looks like there's something going on. And if you look at the delayed image, there's an area, segmental, there's an area of infarction here, but there's an area which is abnormal in the other 2 things, but not here. So there's both hibernating and infarcted myocardium. So we can make that distinction, actually. And then finally, infarction, which is our bread and butter. the myocardium is not viable at all. So all three are going to be normal. I think I have a couple of examples of that. So this is an inferior wall, poor motion. And when you look at the perfusion, you can see that, hopefully you can see that that area down there is abnormal. And then finally, it corresponds to the infralateral wall, which you have delayed enhancement. And it's actually transmural in this case. So you can have, so it should be segmental and it should be subendocardial, which is the weakest part of the myocardium, or transmural as it is in this case. Here's just another example of anterolateral ischemia. So functionally, maybe a little weakness up here in the anterolateral. And then perfusion, you can see there's a subendocardial defect in the perfusion. And finally, it's not quite transmural, but there's a subendocardial most of the way through the wall, late gadolinium enhancement. Now, the extent to which it extends transmurally is important. And that's because of what's called the 50% rule. It is said, and this is again based on a classic study, which I'll show it in a minute. It's said that if there's more than 50% transmural extent of the infarction, then the likelihood of success with revascularization, PCI, percutaneous intervention, or with cabbage, it drops significantly. So you want to have just a sliver of an area. So if you look at this particular example, it's about 50%. So it would be on the borderline, right? Transmural here, the gadolinium enhancement is about 50%. And this is the article just showing as you get the likelihood of revascularization success, when you get into these higher ranges of transmurality, drops into the low percentage figures, less than 20%. Whereas if you have relatively little transmurality and dysfunctional segments, you do better. You can do stress testing also with this. So this is just an example of a normal stress rest stress using, you can do regadenoson, you can do treadmill. We actually do not do this just because it involves a whole nursing component that we don't really have. But the literature on this is actually pretty good. So if you look down here, just a positive up here, if you look down here, you can appreciate that the accuracy, the specificity, sensitivity, PPV and NPV, as compared with SPECT, is actually better for CMR. It's just not the easiest thing to do in terms of just getting the system together to do it. So at this point, echo stress and nuke stress probably have a greater penetration. But I think over time, you are seeing a little bit more of this, and we are starting with a cardiologist, and it may be that we'll be doing that. All right, so then let's turn to what we do the most of in our practice, and that is cardiomyopathies. And I've just listed a couple of, so there's been a tendency over time to think of cardiomyopathies from a phenotypical and a genotypical approach. There's a genetic component to many of them, and a lot of the definitions have skewed in that direction in recent years. But from my perspective, the easiest way to look at it is anatomically. So you can have dilated, which is sort of a classic way, and that's the WHO classification from the 90s. And that's just an easier way for me to divide things. So you can have a dilated, a hypertrophic, you can have a restrictive or infiltrative, and you can have some miscellaneous things like arrhythmogenic RV or ARVD, and there's non-compaction falls in that, and unclassified non-compaction falls in that. But I'm going to really focus on these three top ones, which we see the most of. So again, you can use imaging, MRI imaging, to look at LV, EF, and wall motion. We always do that. And delayed enhancement can be used to distinguish ischemic, which we described as being segmental and generally more subendocardial to transmural, versus cardiomyopathies, non-ischemic cardiomyopathies, which are generally more random, less subendocardial. Okay, so those are our clues. Now, this is just a standard dilated cardiomyopathy. It's a dark blood image just showing a very dilated LV, and again, showing poor EF. Dilated cardiomyopathies may or may not have delayed enhancement. It's not rare sometimes, like this one really doesn't have much. Sometimes you can see a little strip of delayed enhancement along the along the septum mid myocardial. That's very common with dilated cardiomyopathy. I don't know if you can see it in this one or not. And occasionally you get this sort of non-specific, it's clearly dilated and we don't exactly have a reason, but it's certainly not segmental. It doesn't look like a classic ischemic approach. And there's other areas as well. So this is not looking ischemic. So one of the important distinctions is it ischemic or is it non-ischemic? This is going to be non-ischemic. This is going to be non-ischemic. So those are things that, you'd look at. Here's another example showing the same thing. And just to contrast this with, that was non-ischemic. This is infarcted. This is ischemic. So it's very segmental. It's subendocardial. So and it's infralateral in this case. So that's how you would kind of divide it. Now, what about myocarditis? So myocarditis, so once you get into the cardiomyopathy range, non-ischemic cardiomyopathy, is it acute or is it chronic? If it's acute, you tend to think of myocarditis. And myocarditis, in fact, may be a precursor to dilated cardiomyopathy in many cases. The damage may lead ultimately to a dilated. And here's the mechanism that may lead to that, going from acute to chronic over a period of time. The findings in myocarditis actually mimic those of an MI, but it's often in younger patients. You may or may not have much on the SSFP, the bright blood sequences, but delayed enhancement is very common, but it does not mimic what you see with infarction. And so here's a good example. Normal coronaries in a patient who has MI-like symptoms, but look at the way that the delayed gadolinium looks. It's subepicardial. Totally different than what you'd expect for ischemia. So we have a diagnosis. And here's another a 3-chamber view of it. Again, you can see it does not look, you can see the subendocardial part of the myocardium is intact. So this is not ischemia. And then, of course, during COVID, we saw a lot of these, first with the COVID itself, and then we saw it also with the first version of the vaccine. So we looked at that a little bit. And then this is just an example going from acute to chronic, and the fact that over time this rolls out. So this is the delayed showing. This is a patient who has fairly diffuse delayed enhancement, uniform. It's not subendocardial. It's not segmental, so it's not ischemic. And then you look, there's actually T2 brightening. This is one of the other sequences, the supplemental sequences. So this is active edema in 2009. And you look a year later and you can see that a lot of the delayed enhancement has gone and there's no edema at this point. So this is healing. Will it turn into a dilated cardiomyopathy later on? In some cases, it's like PE. Some of them turn into chronic PE and most of them don't. So it's a precursor. All right, what about some other things? Hypertrophic cardiomyopathy. In this case, instead of dilatation, of course, a portion of the myocardium hypertrophies. And it can be, the classic one is IHSS or HOCM, obstructive myocarditis. There's also other variants. There's the apical variant we sometimes see, occasionally these other ones, midventricular and concentric. So just to show you a classic hypertrophic, thickened septum, thickened but less thickened lateral myocardium. And then a lot of times what you'll see is that there's stenosis at the LVOT where my arrow is, and you can see a jet coming through there. Sometimes you can see anterior valve leaflet motion, so-called SAM, systolic anterior motion of the anterior leaflet. That is a classic which I don't know that I see here, but that is a classic look for hypertrophic obstructive cardiomyopathy. If we move on to the apical version of that is non-obstructive. So you can see kind of a spade-like appearance to the myocardium here at the left apex. And you can see it even impressively here sometimes there's a little outpouching in these apical, and they get weird chest pain syndrome. So they will come in symptomatic, but with an atypical chest pain. Another thing which is predictive, so the question with a lot of these obstructive hypertrophs is, are they going to get a defibrillator? Because they're at risk for sudden death. And one of the predictors is late gadolinium enhancement. And in fact, in this case, you can see that there is late gadolinium enhancement. So that's a predictor of a need for a defibrillator, sudden death, and a need for a defibrillator. Then restrictive cardiomyopathy I want to talk about, and amyloidosis is probably, and sarcoid are the two most important. Amyloidosis, of course, is the deposition of amyloid in the heart, may lead to heart failure, sudden death. There are different kinds of it. The thing I mentioned about the TI scout is important here. In this case, you can see the blood pool does not null first. The myocardium does. That's generally a dead ringer for a patient who has amyloidosis. So basically, there's such infiltration of the myocardium, it keeps the myocardium from nulling until it's really the opposite. The blood pool nulls first. So in any event, you get mild diffuse wall thickening, and then you get generally diffuse delayed enhancement. So let me show you, this is not myocardial because it's the entire subendocardial region, and in this case, basically the entire myocardium is showing delayed enhancement. That's a good look, and it's very tough to null these patients. So you might be having difficulty nulling the myocardium here. Sarcoidosis is another one. This is just showing adenopathy, and in this case, you can do the delay. It tends to be patchier. The bright blood images just show nonspecific findings. But what you can see is sometimes edema with sarcoid, because there's areas where it's scarred and areas where you still have infiltrative disease. And by the way, this is the number one cause of, everybody talks about the adenopathy and the lung findings. The number one cause of death in sarcoidosis is this, sudden death. And so if there's cardiac sarcoidosis, and you can see subendocardial enhancement here, so it's not ischemic, it's something else. Is it amyloid? Is it sarcoid? Is it, it's not ischemic. In this case, it was sarcoidosis. Just a couple other newer techniques that are being used. One is T1 mapping, which we use. This is detecting the absolute T1 value, and that's because sometimes if there's diffuse abnormality in the myocardium, diffuse fibrosis, we don't see gadolinium enhancement because everything's involved. And so, for instance, for amyloid, so you can actually look at the absolute T1 value, and if it's elevated, that's a sign that maybe you have amyloidosis. There are other conditions like hypertrophic cardiomyopathy where that will be the case. So we're doing T1 mapping here. You can also do extracellular volume. It's sort of an extension of that. And you can also look for, so these are cases where you suspect something's going on, but you don't have delayed enhancement. So we do this frequently. This is a patient with myocarditis, has an elevated extracellular volume level, and has an elevated T1. The normal T1 should be under 1100 anyhow. And this is a patient that had myocarditis. We didn't see delayed enhancement, but we were able to make the diagnosis in part on that basis. All right, so then I'm going to turn to other things. There are many, but I'm going to talk about structural heart disease and cardiac tumors in particular. So we can go through and just show a few examples. There are mimics. So this is an example of the Chiari network or crista terminalis, which can give you a bump that looks potentially like a thrombus in the right atrium, but it's not. It's a normal structure. And we get referrals from echo thinking that, you've got some kind of thrombus, and in fact, no, this is a normal structure, always in that location. But thrombus itself, we can see as well, and here's a left atrial thrombus, and another one, and these will generally, this is actually a small tumor down here. Generally, thrombus doesn't enhance, tumor generally does. See, there you go, enhanced. And then another benign lesion, besides thrombus and variants, is lipomatous hypertrophy of the atrial septum. So you can see here, classically bulbous-shaped, kind of dumbbell-shaped, between the left atrium and left ventricle. You can see this on CT. It looks fatty. So it looks fatty. You can try to suppress it as well. But this is unencapsulated fat, which spares the foramen ovale. So there's a part up here and a bigger part back here. It's a very typical look with sparing of the foramen ovale. So that's a dead ringer for lipomatous hypertrophy. Here's the fat sat, and you can appreciate that it looks just like the rest of the fat. So you know this is lipomatous hypertrophy, almost always asymptomatic. It just is a worrying curiosity, if you want to call it that. Myxomas, okay, a couple different examples. Most often in the left atrium, but about 70%, about 20% in the right atrium, as in here. You can put them in cine and move them. On delayed enhancement, they'll probably have some increased gadolinium uptake, as in this case, left atrial myxoma, in this case removed, and you can see the path correlate. Malignant cardiac tumors, primary malignant cardiac tumors are very rare. The most common, I'll show you just a couple examples. Angiosarcoma or sarcoma is probably the most common. Generally, angiosarcomas are along the right atrium going into the right AV groove, as shown here and here on dark and bright blood images. Most common, very rare. We've only seen a handful of these. And then here's another one. This is actually you can see areas in here, and on bright blood, you can see infiltrating the myocardium. This was a carcinoid, which was in the heart, actually. And then you can see secondary tumors. On autopsy, secondary tumors are much more common than primary tumors. We do not see them that often on imaging, however. But sometimes what we do see is this so-called contiguous spread. And so in this case, for example, you can see there's tumor or filling defect in the right atrium going to the right ventricle. And this was actually a renal cell carcinoma that had crept up the IVC. And so MRI is very good for this. Here's a lung cancer that's invaded through the pulmonary vein, inferior pulmonary vein into the left atrium. MRI is very good. Not that CT won't show that. I think, yeah, CT will show that as well, but MRI sometimes, for whatever reason, shows it as well or better. And then I'll talk briefly about congenital heart disease, very briefly, because it underestimates, my discussion here underestimates how good this really is. It does many, many different things. Just to show a couple of examples, this is a sinus venosus ASD. We know that that is often correlated with partial anomalous pulmonary venous return of the right upper lobe, as shown here. Depicts it beautifully. Could you do a CT? Sure, but a lot of these patients are younger, radiation, blah, blah, blah. So the MRI is really useful. And in this case, you can do it as well, which you can't do on CT. A QPQS, show the shunt fraction is nearly 3. That needs to be repaired. Here's another patient. You can see a jet. This is a patient that had a TET. It was a TET, got it repaired. And what you can see here, the pulmonic valve is here. You can see a jet from post-repair pulmonary valve regurgitation, which is going to need to be fixed. So those are a couple of examples. And I didn't even get through all the topics here that you could possibly talk about. But some other things, pericardial disease. So this is an example of pericardial constriction or constrictive pericarditis. And you can see that the RV, LV are very, very restricted here by this thickened pericardium. See, they're hardly moving. And the atria are big. And you can actually see what's called a septal bounce even if you look at this. So that's just another example. I showed you valvular disease when we were talking about aortic dissection. Aortic disease we use it for. Left atrial evaluation. Here's an example of tricuspid regurgitation. You can see a puff coming off the tricuspid valve there. So many, many, many different indications for cardiac MRI. It's just a tremendously valuable technique. It's a great complement to cardiac CT, has particular strengths in cardiomyopathies and ischemic imaging. And so this is another growth area for us along with cardiac CT. So I really want to, even though I know it's not something that, as many people are doing, it's something I really want to give a plug to. And so with that, I want to wish everybody happy holidays. I want to thank John, the organizers at World Class CME, all the tech help that we got. It's been a wonderful occasion, and you've been wonderful to hear me out, and I really appreciate it. Thank you very much.